if you are not able to scan, please go ahead and put your name and your organization on the chat, as we do take attendance.
Okay, so shall we get started since
Yes.
Claudio and Representative Exum and I are all here?
Yeah.
And we have 48, well, we have 45 attendees beyond that.
Yeah.
Okay, so I just want to welcome everyone. I'm so sorry not to meet in person again for the second month, but it is great to see 48 members already here, and I'm very much looking forward to hearing from the schools and the providers, CHDI and school-based health centers, as well as Bristol and Hampton Public Schools, about what they're seeing with children's behavioral health and the impact and the successes and some of the concerns that they have. So with that, I will just say great to see you all, and thank you so much for the work that you're doing, and I will pass it over to Representative Exum.
Good afternoon. Thank you so much. And it is wonderful to see you. And I see the pages continuing to expand. So as more people join, and I think this is an incredibly timely discussion as we wrap up another school year. And I was just reflecting on where we were, what we were listening to post-pandemic when we really started this work with 5001. And I'm very interested in seeing where we're coming, what you're seeing, and what kind of recommendations you have and what we can do moving forward as a committee. So it's good to be rejoining you all again, and thank you so much for your time this afternoon. Claudio, on to you.
I'll just say, yeah, I think it's very timely as we end the school year to sort of finish off and round out our conversation with the school-based health centers and services we provide. And I'm really interested to learn, and I'm pleased that we actually have superintendents who are in the field who can give us a real world example of how this works and where there may be gaps. And I'm also looking forward to a quick debrief of the legislative session. It's hard to believe that we wrapped up almost a month ago, but we'll be in full implementation swing soon enough. Thank you.
Thank you. Thank you. Israeli, do you want to share the screen very quickly? Just a quick introduction. Erica Nowakowski, Executive Director of the Tau Youth Justice Institute. Again, just friendly reminder to please enter your name in the chat for attendance, and or you can scan the QR code. Also, we just need to call for the chairs to call the acceptance of the March meeting minutes.
So I do have one slight change on the meeting minutes.
Sure.
In the very beginning, where it references who was there and speaking, if we could just add representative to the front of Representative Exum's name, because it says Tammy.
Okay, absolutely. Any other changes?
If not, then I move that we accept the minutes.
Second.
All those in favor?
Aye.
Aye.
Okay, thank you. All right. Okay, very quickly, I just want to give a very brief update to you all around Monday, June 3rd. Will be our TCB legislative strategic planning day. Israeli, if you can lower the screen, that would be great. It'll be our TCB strategic planning day. We do currently have, we are at capacity. Many of you are attending, and we're very excited to have you there. I believe the last count was Israeli was over 40. Is that correct? I think we were close to 50.
We have about 50.
We have about 50 or so members of the TCB committee attending, as well as parents with lived experience will be attending the strategic planning day on Monday, June 3rd. That will be held at Middlesex Community College. Thank you. We have 58. We are on capacity, so we really don't have any more room, but if you are not able or you weren't able to reserve your spot or register for Monday, please know that this is not the last day. This is the first of multiple series of activities where we will be engaging you, the membership, in the development of your strategic plan, which is scheduled to be released in December of 2020 of this year of 2024. And the plan for Monday is a brainstorming on goals, and also on identifying strategies to achieve those goals. But again, this will not be the only time that we will be engaging the TCB membership and its work groups in strategic planning. We will be doing that throughout the summer. So if you were not able to register for Monday, please know that we will be in touch with you. We will be capturing as many voices as possible on the strategic plan. We will have breakfast and lunch for you. Registration starts at 8:30, but the program begins at 9. But we will have coffee, bagels, and so forth. And then we have a lunch for you. We'll have a lunch break, and then the day ends at 4 o'clock. If you have any questions about the Monday, please feel free to contact myself or Israeli. Okay, and then now moving forward with other items on the agenda, we'll just dive into the school-based presentation. Just a little housekeeping, Israeli and Gina, who's managing the screen? Who would you like us to do it, or?
Sorry.
Okay, we're managing the screen. Okay. All right. So I apologize for the technical difficulties there. Thank you. I'd like to give the floor to Gina Bracey with the Child Health Development Institute, Associate Vice President of School and Community Initiatives, to the floor to start off the presentation. Gina?
Thank you so much, Erica. Thank you to the tri-chairs for inviting us here today and for the rest of the committee. Definitely looking forward to sharing information with you about our work at the Child Health and Development Institute, or CHDI. We'll be starting with just kind of a brief overview or introduction to who we are in the work and our role in school mental health. We'll be presenting an opportunity for you all to get involved in helping to continue to expand this statewide. And then we'll end with a few action items, a call to action about what we can all do moving forward before I turn it over to the others, the school-based health centers and the district folks who I know you're most interested in hearing from today that are kind of on the ground doing this work. So Israeli, should I share my screen or you share yours? Oh, thank you. Perfect. Perfect. And very good. Okay, we can go on to the next one. So, okay. Oh, to the one before that, sorry. So just to introduce CHDI. So again, we are an independent nonprofit for children's behavioral health in the state. We work to be a bridge to better behavioral health with the goal of really making sure that all children grow up healthy and thrive. And we do this by advancing effective systems, practices, policies, with a goal of resulting in equitable and optimal health and well-being for children, youth, and families. We work to empower policymakers. We work together with all of you. We work with providers to serve as a champion for the work that they're all doing, and also to kind of spark and bridge partnerships across all of the stakeholders, really as a neutral convener in this work. And we have 4 areas of expertise at CHDI on the next slide. Systems development and integration is a primary area of our work, as well as evidence-based and best practices. Many of you know us best from that work and kind of disseminating that across the state, as well as our quality improvement area. And then finally, our comprehensive school mental health area is our 4th area, the one that we'll be talking about today, where our goal is really kind of helping build a comprehensive and sustainable system to promote healthy development and to, again, kind of improve the way that behavioral health needs are identified and treated in schools so that students can reach their full potential. So if we go to the next slide, I'm kind of jumping right into some of the resources and current initiatives that we have going. We're not really spending time on the need. I think all of the presentations that have led up to this one over time for this group have really set the stage in terms of knowing that, particularly coming through the pandemic, that needs are increasing, that the acuity is there. There's more intensive needs among children and youth in the community, and that's the same that we see in the schools as well. In fact, I was at a school this morning, an elementary school, and you can feel it. Everybody's ready. They're kind of burnt out. They're ready to get to summer break, counting down the hours and the minutes. If any of you are the other school folks here on the call today I'm sure can relate to that. So I'll jump into some of the things that we are currently doing that is involved in the school mental health space here in Connecticut. So one is around assessment and planning. So the SHAPE system is a tool for that. It's an online portal managed by the National Center for School Mental Health at the University of Maryland that really helps to identify, as a needs assessment process, the needs, the strengths, and strategies that schools can use to improve quality and sustainability of school mental health systems. And this is really an important first step for schools to help identify what it is that they currently have that's working, what kinds of things might not be working so well, and where are the gaps in terms of their comprehensive approach to doing mental health work in schools. And so this is something we provide free technical assistance and support to any schools who want to use the system. And it's kind of the cornerstone for all of our other initiatives as a starting place for helping to identify those needs. So the next block is system building, really working then to build that foundation around comprehensive school mental health. The Connecting to Care grant is a component of this, and I'll speak briefly about that again later. But here we're talking about those bigger systems level initiatives that kind of look across school levels, look across, the multiple tiers and systems of support, again, which I'll show in just a moment. And much of this work actually built off of the Project Aware grant that Connecticut had that was awarded to State Department of Education that ended about a year ago to kind of really pilot and develop this kind of approach. So the next one is trauma screening. Again, another critical component to all of this is helping to identify what students need supports, where those students are that have experienced trauma or are experiencing symptoms of trauma, and how to best meet those needs. And so the trauma screen time course was something that was launched by CHDI in October of 2022. It's free and online, and again, another way for school staff and folks working with schools to help identify student needs. And then the next obvious step would be trauma treatment. So CBITS, the Cognitive Behavioral Intervention for Trauma in Schools, and Bounce Back are group-based treatments that happen actually in the school setting to help students who have identified trauma needs. And since the course, the trauma screen time course has been launched, we've had hundreds of folks already trained in that and seeing more students being identified and served to meet those trauma needs. If we need to move to the next level, diversion of arrests. So school-based arrests, or the school-based diversion initiative, is really our longest standing piece of work in the school mental health area, going 15 years back now. That was developed again in partnership with the Department of Children and Families, the Court Support Services Division of the Judicial Branch, State Department of Education now kind of funds and manages that project. And we also work closely with DEMIS as other partners on that work as well. We have had great success with SBDI. 73 schools have been served in that initiative over our 15 years and across 26 districts, and have reduced the number of school-based arrests on average about 29%, and are increasing the rates of mobile crisis referrals. So again, connecting students to care by about 55%. We are excited to be launching our school-based diversion initiative, early intervention initiative. That's where the E comes in for SBDIE, to expand this to elementary schools. So it's been in middle and high schools, and we are currently now have additional funding to be able to pilot that in elementary schools. So that's another exciting development. And again, an area that's really needed. So I know this group has been paying attention to what's happening with the younger kids, and those earlier points of intervention are so critical. So the next one is the peer-to-peer support for students. Again, this is another brand new initiative. This actually came out of legislation PA 2247 that charged DCF and SDE with developing a peer-to-peer support model for mental health among students. And so that is actually launching now as we speak, as well as recruiting schools to participate in that pilot. So again, another critical piece that has been missing in terms of having students supporting each other through this, because a lot of times students are talking to each other before they're going to a trusted adult to actually be able to assist and move them on to referring for treatment as needed. And finally, another piece of this obviously is around professional development. And so helping the workforce with competencies around school mental health to kind of shore up their learning and being able to apply this through the work. And so our Educate Smart portal, which stands for School Mental Health Assessment and Response Training, is available for all of the folks participating in these initiatives and beyond. So we can move to the next one now, just to, this is just going to be really quick, just to show that all of this work is grounded in our comprehensive school mental health framework, which really serves as a blueprint to guide how this work rolls out in schools. And again, this is where the comprehensive piece of the model comes into play. So it's beyond that traditional three-tier pyramid that everybody is most familiar with, that looks at what happens universally for all students in the school, as well as those then that are selected and may have some warning signs or identified needs, and then up to tier 3 for those indicated supports for students with the highest level needs. But it takes that and kind of steps back a little bit and includes, very importantly, the school workforce and the professionals in the school as well. So professional development and support for a healthy school workforce, and grounds all of that in family, school, and community partnerships, where again are the most important foundation for making sure all of this works and holds up. So if you want to know more about that publication there to the side has more on that model. So moving on to the next one quickly is just, again, I had mentioned would talk briefly about connecting to care. So the Connecting to Care or Connect grant, again, is the Systems of Care grant for the state of Connecticut. This has been awarded to the Department of Children and Families. This is the 4th round, so we've been calling it Connect 4. CHDI has served as the statewide coordinating center for this work for the Connect grant since it started back 10 years ago. And this round of the Connect grant is so important because it really shows the importance of strengthening the school mental health component of our larger system of care to make sure that there's integration between the school and community-based behavioral health network of care, that we're really working to increase staff and family knowledge about what's available. We often hear that families aren't sure of what's out there, they're not sure how to access it. Or maybe there's definitely stigma, and particularly in different areas of the state and different communities, access can be a challenge. So that's another important goal of this work, increasing the capacity to access and utilize the behavioral health resources and supports that are already available, and making sure, again, that those are equitable and comprehensive, so that all kids have access to those and to be able to benefit from that work. So if we go to the next one, this is, again, just a very brief graphic of how this work rolls out when we work with schools. Again, we're providing training, technical assistance, support, and quality improvement and data work with schools to make sure that this work is implemented sort of across the board and over the time frame that's available to schools to work through the school year. So again, I mentioned phase 1 and the importance of starting with that SHAPE assessment as kind of step 1 in identifying what the needs and capacities are, and then moving through the process into developing an implementation plan, reviewing that consistently, checking in on a monthly basis, and always working to build sustainability over time. And so if we go to the next one, we're talking about, again, all those initiatives that I mentioned. Through the last fiscal year, CHDI has worked with over 360 schools across all of those initiatives that are there listed on the screen. And again, you see lots of gray area, and the gray area means they haven't been engaged in these specific components or initiatives that CHDI is involved in. Of course, our goal is to reach all 206 districts, and we know that they all have they operate very differently and somewhat autonomously. And so getting to all of them is really critical for ultimately building up the statewide capacity in a way that works for all kids. So again, this is just the work that CHDI is directly involved in, and we know that there's so much more happening in the state. Particularly, we'll hear about school-based health centers. The next slide, though, is another important component of the system that we just wanted to highlight quickly, is around mobile crisis. And so I know that was a request of this group as well, in terms of how to mobile crisis interface with schools. That's very important, the role of that mobile crisis plays. That you can see by the purple line there on the top right. This is the percentage of referrals that come from schools to mobile crisis service. So the purple line is at the top. It's about 46% of referrals are coming from schools. The blue line is next, which is about 38%. That's how many referrals come from families. And then the red line towards the bottom is about 8%. That's how many are coming from emergency departments. Again, these are referrals directly to mobile crisis data, and this is their data from DCF. And so, again, this is just shows sort of the importance of that connection and making that available through schools and helping them understand when it's appropriate to call mobile crisis, how mobile crisis can be a key component of their service delivery, and particularly in moments of crisis and need. And so again, you see the interesting flip-flop of the blue and purple line there. That's during COVID, of course, primarily when schools were closed. And so schools were not making referrals directly to mobile crisis service. Families were at that point, but it's kind of reversed again, and schools are a critical component of that piece. And we know that, students spend the majority of their time in school. And those that seek services of students, about 70% of them are getting services in schools. And so, again, that link is just critically important. So I can't spend more time there. I'll move on to the next piece, but it sets up the opportunity that we have then to kind of figure out what else is missing and what are the key components of the system overall. Again, there's so much more happening than what CHDI is doing. Both in Connecticut as well as nationally. And so we have the opportunity to do that through a landscape analysis process. And this is where all of you come in as being key stakeholders and helping to advance this work. So this is in partnership with the State Department of Education and Department of Children and Families through our ESSER funds to conduct a landscape analysis and a report to summarize the national best practices, as well as those things that are happening in Connecticut for supporting student behavioral health and well-being. And so we want to really get a clear picture of what else is out there, what's working well, what kinds of things are we missing, how can we better integrate, expand what needs to be to be grown and supported. And this is being done with the same approach that was taken with the report on strengthening behavioral health workforce that came out last November. So if you're familiar with that work, I know that's been presented here as well briefly. That can help give you a sense of kind of the direction we're taking with this. But briefly on the next slide as well, to show you kind of how this all rolls out. The process is going from, it started sort of in March and is moving through the end of this year in December. And the first step is really kind of identifying the content. So we want to know, what are the strengths? What are the needs? What's the capacity of the current system to support student behavioral health? And what is missing, as I mentioned. So this will be done through literature reviews. We're looking at research, at gray literature, at best practices in Connecticut, as well as other states. And we'll be also looking at reports on outcomes of initiatives that are in progress and what kinds of things are they doing, what's working, what are the outcomes for students and families. We'll be doing extensive stakeholder input. So we will be doing some surveys, some focus groups, key informant interviews. Again, we're looking kind of broadly across all stakeholders in terms of students and families, educators, administrators, national and state level experts, policymakers, providers, state agencies, pretty much anybody that's listening to this call and that's engaged and interested in supporting student behavioral health. We want to hear from you. And the goal, again, the final report then will kind of develop a set of recommendations and an action plan for actually guiding policy and system level and practice level recommendations for strengthening schools' ability to support behavioral health and students' well-being over time. We also have an advisory board that's engaged with us to support this work. And again, ultimately, we're looking to get as much input as possible and get a strong landscape picture, right? A picture of what the full landscape is that can support this work moving forward. So moving into the final slide, just on a few areas and call to action. Again, how do we make this most actionable? So the first one is really about informing this landscape analysis process and helping facilitate the recommendations. So we want the input, we want to help drive what happens, what goes into the recommendations, but most importantly, what happens after the report, because that's just the beginning. It's really about how do these get implemented? What are the actual action steps we can take to make improvements, and how do we continue to monitor those over time? One way, again, is through expanding comprehensive school mental health systems expansion. So, and we talked about, there's 206 public school districts here in Connecticut, and they all operate somewhat autonomously and differently. And so what's the benefit of having a comprehensive set of goals and guidelines and strategies around how best to approach school mental health with quality and sustainability? And that is one of the goals that we feel needs some support around as well. Embedded in that is infrastructure support. So making sure that there's sustainable funding to do this over time that includes being able to develop data systems, and particularly data systems that can talk to each other and can summarize information, but also can disaggregate information so we can see what works for specific groups of kids and specific families in specific areas of the state, as well as the bigger picture of what's working more holistically for all. The workforce needs, again, we've talked about that here, but continuing to train up and support and provide a strong pipeline for the workforce to do this work. And then coordination support, so making sure that there's an entity there to help guide and support and train and do the work that supports the direct service behind all of this. Integration of crisis services. So again, we briefly mentioned the role of mobile crisis as urgent crisis centers expand as well. It's an increasingly important role within the system, and making sure that schools understand how and when do we refer to them? Do I have one in my area? What is the capacity? What does that mean when kids are transferring back and forth between these services, or even between other settings? How does that work with schools? And then finally, we have, and I would say most importantly, family and youth engagement as always. It always needs expanded, always needs, increased attention to that, to make sure that that's really being guided and driven by the families and youth that are actually most impacted by all of this work, so that we can make sure that there's optimal and equitable outcomes across the board. So with that, I will pause as we transition to the next one. I think we're holding questions till the end, but I would be happy to hear from anyone at the end or offline at another time. So thank you so much, and I'll look forward to the discussion at the end.
Thank you, Gina. The next person scheduled to present is Melanie Wild-Lane, Executive Director of the Connecticut Association of School-Based Health Centers. Melanie, are you on? There you are.
I am. Thank you. Yes. Thank you. Thank you for having us today. I'll start with just sort of an overview of what we've been asked to provide for you all today, which is an overview of the association, our school-based health centers and their importance, the impact that COVID had on our students, our school-based health centers, mental health, some of the challenges that we faced, some funding concerns, and we'll end with some of our recommendations via a task force that we sit on. So I'll back up and give you a little information about the association. For those who don't know, our mission is that through advocacy, education, and networking, the association positions school-based health centers as leaders in a broader healthcare system for Connecticut's children and adolescents. Our vision is that all children and adolescents in Connecticut will achieve and be achieving at their fullest potential. So for us, our association works towards that vision by supporting a large and very growing network of school-based health centers. I think we're currently at 316 across the state. Now, what are school-based health centers? So school-based health centers are comprehensive primary care facilities. We're licensed as outpatient clinics or as hospital satellites. School-based health centers are located on the campus or in the school, and we serve grades pre-K through 12. The centers are staffed by multidisciplinary teams of pediatric adolescent health specialists, which include nurse practitioners, physician's assistants, social workers, physicians, in some cases, dentists and hygienists. We are not the school nurse's office. We're different, but we work in conjunction with them. So the difference is that our providers, medical and mental health, can assess, diagnose, and treat. And so that's the benefit of being in the school-based health centers. You can go to the next slide. Services in our school-based health centers can include any combination of these three. It is up to the school board, the district, and the community to determine what their needs are, and then to seek out sponsoring agency or subcontractors to provide those services. You can go ahead. So school-based health centers have been around since the 80s. We are blossoming right now, I think, because we are safety nets for lots of our students and families. But why is that? Because we've built strong partnerships. We built partnerships with our legislators who support school-based health centers, who strive to understand what we do and how we do it and what our best practices are. We've increased our school district awareness. And so the association and our school-based health centers have reached out, met with leadership in school districts, and worked in partnership with them. I think one of the biggest things that came out of COVID, and maybe one of the best things that came out of COVID for school-based health centers, was that we could implement telehealth service. And thankfully, this year, telehealth services were not given an end date and are reimbursed through Medicaid. So that was a win for us. But it allows us to be able to pull in all of the teams that work with the children. So anyone who cares for that child outside of the school-based health center can be pulled in through telehealth. We can pull in families, we can pull in school partners, and we can pull in psychiatrists. So we're taking away the med management piece from our primary care docs who are already inundated with other things, and we're putting it with the specialty. And then through that specialty, we're able to involve all of the components that are involved with our children. So that's a big win for us. And then state insurance. So Medicaid is, as of July 1st, will expand and cover undocumented students up through the age of 15. That's a win. We were hoping that this year we would push that. I think we pushed it as far as we could push it, but funding is always an issue. And so we'll continue to work towards increasing that age up through the age of 18, past the age of 18, because there are students with disabilities who are in our schools and do have Medicaid. And so we'd hope to cover to the age of 21 at some point. And then I think we're important. We've created a venue where providers sort of flock to us, not because we have this great school schedule, which everyone thinks is the reason. It's because we get to work in this atmosphere that is so very different as far as our mental health providers are concerned, so very different from working in a clinic where you don't have access to all of the primary care providers. You don't have access to school staff and leadership staff in the schools to discuss what's happening. You don't always have easy access to families. And so we have this great role that our mental health clinicians are just loving. And then we have this huge increased visibility, and I thank the legislature for helping us become more visible because they're talking more about us. And they recognize that there's a huge need for school-based health centers as a safety net, not as a primary care provider, but as a safety net. You can go ahead to the next slide. So what did COVID do for mental health? It did a lot. It pushed our mental health providers, and I know that I have a partner here, Jason, who works for Child Family Agency of Southeast Connecticut. And he'll jump in at some point and probably say, absolutely, this pushed his mental health staff to the brink, right? And it opened all these gaps. They weren't just gaps. They weren't just fissures. They were like crevices in our system. And I see our legislators smiling. They know they weren't gaps. They were just big, huge crevices in our systems. And our students were flocking to the ERs. They were flocking to urgent care. They were running to the school nurses when the schools were open. And there just wasn't enough. There weren't enough people for this crisis. And then 2021, the Surgeon General announced that our youth were in a mental health crisis. We knew that. But we needed visibility on those words. You can go ahead to the next slide. So what did we learn through COVID? So much more than this slide could even talk about, and more than you'd give me time. But the first thing was that we needed to expand our mental health services, and that included our school-based health centers. We needed more funding. We needed to be able to train teachers not to be mental health providers, but to be aware and do an initial assessment. This child's in my classroom. They are not acting out because they don't like me and they don't like the assignment, or they don't want to do the assignment. They're not coming to school because of me, but I need to just sort of flag that child. And how do I flag that child? And so we needed to put in some training for teachers and paras so that they could be more aware of what was going on in their classroom. And then what was the resource after they flagged that child? Who were the resources? We also learned, and I think a lot of us in the field knew this, but again, sometimes you need to shine a big light on it, that there were inequities in who could access mental health services. So for school-based health centers, anyone can access services regardless of race, ethnicity, economic status, insurance status. You could reach us. But we're not in every school, and we're not in every school district. And then those who did not have access to our school-based health centers, and you'll see in a later slide, HRSA talks about where the pockets of deficits are, where our mental health providers are not. But we were able to identify what those pockets were, where there were deficits, where there were inequities, who could not reach out and find a provider. And then what we also learned was that there were underrepresented populations that could not access mental health services, but there were also, and this includes in school-based health, there's also a provider underrepresentation. So we have worked over the last 40 years to increase the number of providers who represent the populations they serve. But we, just like private clinics, are struggling with that. For the majority of my career, our clinicians have looked like me. They maybe have been a little bit younger, but they've been primarily white females. And we realized that our students, and we realized this by talking to our students didn't want to talk to me. They wanted to talk to somebody who looked, came from, spoke like them. And so that was another big crevice. You can go ahead to the next slide. During COVID, and I feel like I've said this for 4 years, so during COVID, we saw the same trends that primary care providers and private practices were seeing. So trends included obesity, difficulty with peer relations, identity concerns, school avoidance, schools being open, then closed, and being afraid to go to school, anxiety, depression. And then there was this great rise in social determinants of health. We've known they've been there. We know what they are. But we saw populations of students who didn't have any of these determinants prior to COVID, who now have food insecurities, financial insecurities, parent lost a job, maybe they lost housing. And risky behavior started with came with all of this. And so that was different. And that was, that rose to the surface very quickly during COVID, during the early stages of COVID. Next slide. And for all of our kids, the biggest barrier is access. We don't have enough providers to meet the needs of our kids. And I'll go on to say that we can't compete with other states. Our reimbursement rates are low. And I know we are working to increase those reimbursement rates. Our reimbursement rates are very low. Our salaries are reflected in those reimbursement rates and the lack of funding. And so we're not pulling in the workforce that we need to serve the students in the numbers that we have. Next slide. This is the HRSA slide that I was talking about. And I think this, from many of the folks who sit around this table and for our legislators, this is nothing short of new. This is not new. What you're seeing here are the pockets around the state in blue that have a shortage in mental health providers. So you'll notice it's the corners of the state, right? It's our big cities. It's Hartford, it's Waterbury. I just met with the health department in Waterbury. They're significantly concerned about the status of their kids in that city. New Haven, Bridgeport. So this is not a surprise, but just something to be aware of and mindful of. Next slide. So our challenges, I think I've talked about a lot of these throughout this. Our challenges are that we don't have enough staff in our workforce. We can't compete. There's a high burnout rate. Competitive salaries are non-existent. And I think, Jason may at some point pop on and say that it's absolutely challenging to recruit with the limited funding. And then again, our caseloads are huge. Our caseloads are huge. The demand is increasing every day. I talked about insurance reimbursement and the inequities of that. And there's a need for psychiatry and case consultation and referrals outside of the scope of school-based health centers. And so being able to draw those disciplines into the state is what's also needed. Go ahead to the next slide. So there were some good things that came out, and there have been some significant funding sources. It is one-time funding. So this slide doesn't represent it, but during COVID, DPH received CARES Act funding in the amount of $12 million allocated specifically for school-based health centers. Unfortunately, that funding was not released until 2023. And so our school-based health centers have just received that funding this school year and been able to spend it when it was so desperately needed 3 years before that. Again, it was one-time funding. And then 2022, SB1 came out and was to expand school-based health center services with a focus on mental health, extending hours before and after school to meet the needs of families. That was $12 million. That went through DPH. They put out an RFP recently, found a fiduciary, and then the fiduciary's RFP went out 8 weeks ago, and the award will be given next month. And so this is funding that the legislature voted on and allocated 2 years ago, and we have not received it yet. And so that is a huge concern to us, because when we then turn around and meet with the chairs of all of our committees that we historically meet with every year, they say, where's the data? What's the data behind the funding that we've given you? Where did the money go? And unfortunately, at this point, we have no great answer for that. So if you go to the next and final slide, CASBAC is part of a task force that the comptroller put together. It's the Health Cabinet for Children. We sit on the subcommittee, and that subcommittee made several recommendations to the comptroller that may or may not come to fruition. However, that our committee felt were very, very important. Value-based care, to pilot that within the state, to come up with a funding model that's flexible, to really iron out who our target populations are. And then we have such a great collaboration through the state and so many amazing resources. But unfortunately, we have a lot of task forces working in silos. How do we pull all of those task forces together and all of those agencies to have really great interagency collaboration? And then data. We're all sort of collecting data in silos as well. And so how do we share data well? And what data do we share? And then, always and forever trying to find relief payments and services for our families. And so I'm gonna end there, but I'm gonna ask that Jason from Child and Family Agency talk a little bit. We didn't do a slide on it, but talk a little bit about the successes. So I'll take you I'll do all the negative stuff, and I'll let Jason take on some of the amazing successes that our school-based health centers have had, instead of focusing on all of the challenges.
Absolutely. Good afternoon. Thank you for a few moments to speak to this esteemed group. I'm Jason Shirley. I'm Behavioral Health Program Manager from Child and Family Agency. I've had the honor of leading and being a clinician in school-based for 17 years now, and worked with school programs for the last 24 in Connecticut. As both of my colleagues have said, Since the COVID year, the mental health need in Connecticut is higher than ever before. We see that both in the quantity of referrals and in the acuity. And there's a real dearth of higher levels of care available. So our school-based health centers have frequently served clients who have severe suicidality, physically aggressive behaviors that we wouldn't normally before. I think the biggest thing that I took out of the 2020-21 school year is when families went remote or hybrid, we lost touch with them as a community. We didn't know what the needs were. Frequently, our schools were not able to refer them to services because they simply didn't know what the parents and students were going through. And so I think what school-based health centers took away from that is the next evolution of mental health care is finding ways to bring services to the clients. To move away from the traditional community model where clients come in and to actually find ways to make them accessible. So school-based health centers are really primarily suited to meet this need in this moment. As some great examples, we, both our medical providers and behavioral health providers at Child and Family Agency, are trained in the Columbia Suicide Severity Rating Scale. So students experiencing any kind of risky statements or suicidal thinking at schools, they can be evaluated by us no matter what service they're seeking. We collaborate in an interdisciplinary fashion. And now in Southeast Connecticut, we can actually refer them to our Urgent Crisis Center, which we receive funding for. And so we're really able to identify those most at risk in the moment they're at risk and intervene in that moment before things get any worse. You know, our colleague from CHDI mentioned CBITS and Bounce Back. We've been very proud this year to be able to provide CBITS and Bounce Back in 18 different schools across 5 towns. The rise in trauma symptoms in children since COVID is innumerable. And so being able to provide an evidence-based practice that is specifically designed to serve clients in schools has been invaluable. These are things that school-based health centers can provide that you would not necessarily be able to access or receive in the community. You know, these brave, Melanie mentioned some of the funding that's came out. Child and Family has been able to expand to 22 school-based health centers. We added 9 new school-based health centers this year. That's led to 3,300 unduplicated users across 20,000 mental health and behavioral health visits. Those are all families that, because of environmental barriers or cultural barriers, would not necessarily have been able to access services otherwise. So we are in the community. We're at the point of service. We're providing the risk assessment, the trauma treatment, the trauma-informed lens in partnership with the school that is desperately needed in this moment. The proudest part of being a leader in school-based all these years has been the incredibly dedicated professionals that I work with. These are people in 2021 that went in and worked in person in schools in the middle of COVID before there was a vaccine released, when many mental health associations went to fully telehealth or hybrid associations. They have never shied away from a challenge in helping meeting the moment of this crisis in our community. But as Melanie mentioned, burnout and turnover is very high. And we do exit interviews at CFA. And the reason people leave is actually money across the board. We don't hear quality of life. We don't hear career opportunities. We don't hear, I didn't get sufficient training or support. What we hear is, I'm going somewhere to make additional money. So in order for us to sustain and continue this incredibly needed service, we do need additional support from the Connecticut legislature. And I know you're already doing everything you possibly can in this moment. The 9 school-based health centers that we added this year, as Melanie mentioned, it was 1-year funding. We've been unable to secure additional funding at this moment from this legislative session. Child and Family Agency is going to do everything we can to preserve those services for the next year, but we really need in the next session to consider additional funding for school-based health centers to make sure all those services and all those interventions in the moment on site that I mentioned can continue, and that those brave and dedicated professionals can continue to be motivated and engaged in the work that we do. So I very much appreciate a few minutes to speak to everyone, and thank you. I think this is a really important conversation at a really
I understand, Melanie, that you have to jump off, so we can make an exception to if there are any questions that I see Senator Austin. So perfect timing. If there are questions, please feel free to ask now, as I understand Melanie has to jump off soon. Senator Austin?
Thank you very much. So my understanding is that school-based health centers are in different silos, even amongst themselves. So for example, school-based health centers in 3 of the schools in 9 sites are going to be closed down on June 30th in Ledyard, Groton, and Stonington. We found out about this at the tail end of session and attempted to address the issue, but do you know how are each one of the school-based health centers handled? What are the options that we have that will help out with these school-based health centers that are closing down on June 30th, having just opened up in last year?
Melanie, we can't hear you, Melanie.
Sorry, sorry, can you hear me now?
Yes, now we can. Thank you.
So Senator Austin, that's a great question. And I think one that gets posed to us every year. No one size fits all for our school-based health centers. That's correct. And one-time funding is great funding. It meets the need immediately. However, our school-based health centers look for other funding sources. So that may be Medicaid reimbursement, commercial insurance. We do bill for both. But with high deductible plans and high copay plans, those services are often free, right? So we bill towards the deductible, and then if the family pays their deductible to the school-based health centers, then they do. But there's only one school-based health center sponsoring organization that sends a bill out. All the others do not. And so our sponsoring organizations look for foundation funding primarily. They rely, if they're a federally qualified health center, oftentimes HRSA will come out with funding. And so there's additional funding opportunities, but it's really piecing it all together. It's a very fine puzzle. And so if their sustainability plan is not written in stone, it makes it very challenging to open and then continue to open, right? Because if you have a high Medicaid or high undocumented population, you're not going to receive the reimbursement and be sustainable, right? You're relying on Medicaid, or it's a free service for those who are undocumented. And so if you have a high population in your area, your program's not sustainable without additional state funding, HRSA funding, or foundation funding. And it's imperative that sponsoring organizations are searching out those avenues.
So you saw the outline on this map of Connecticut, how desperate it is for mental health care in Eastern Connecticut broadly. And
Yes.
in this section of the state, where we have a large military population, a large indigenous people population, these are the military population has TRICARE, which is not very good. Does not cover the costs of any medical or mental health. So if someone could send me options where we can go to try to get this funding so that these brand new 9 sites are not going to be closed down on June 30th. Essentially putting Eastern Connecticut in even deeper color of no services at all. That is something that, and it was $1.2 million that they needed to keep all 9 sites open. And I'm certain that does not include a living wage for the providers that are there. But it is a problem in Eastern Connecticut that whenever we open up these sites, we just can't. They're not sustained. Not that they're not sustainable, but they're not sustained because the funding just does not end up going towards the eastern part of the state. In part because our population is so dense. It's not so dense. It's so sparse that it's just not paid attention to. Now, in these 9 sites will essentially be shuttered as of June 30th. So I just wanted to point that out. And other people are saying, can they respond to the question? But that's a problem for me. Because we just cannot seem to find anything sustainable in Eastern Connecticut. But thank you for letting me ask the question. Thanks.
Representative Nuccio?
Thank you. I'm kind of going to follow up on what Kathy just said. And I just want to confirm something you just said. So if somebody is billed Medicaid or private insurance, we're not sending bills, like follow-up bills.
So for most of our school-based health, so all of our school-based health centers bill Medicaid and commercial insurances. If there is a student with a plan who has either high deductible or a copay, we bill towards the deductible, but the deductible is not collected. Does that make sense? There is one sponsoring organization that will bill for the deductible and or the copay. But for the majority, the other 99% of our school-based health centers do not send a bill for the copay and do not send the bill for the deductible.
I think that's illegal.
So to not bill for it is illegal. To not send the bill or to wipe it clean at the end as if a parent didn't pay it is not illegal.
But if they're not paying it, right? So you're billing the insurance company. They're saying you have to hit the deductible. That then goes towards their deductible maximum, and you're not actually collecting it. I really think that's illegal. I work in the insurance industry, and I think that is not allowed in the state of Connecticut. You can't wipe off a deductible if somebody's not paying it. So that is very concerning to me. We may want to look into that. And then you mentioned something about all undocumented care is free.
Yes. So any student who does not have insurance is provided services without being billed. It's free of charge.
Okay, so what is your, I guess I'm listening to what Kathy said here, and we've got centers that are closing and stuff like that. I guess I'm not quite sure how your funding model works here. Because
So
if we're not billing for these services and we're not collecting bills that are due, is the expectation that the taxpayers are just going to pay for this? Like, I guess I'm confused what the funding model is for these school-based health centers.
Yeah, so the purpose of the school-based health centers is to provide a service to students who would not otherwise be able to access, right? And so that means our undocumented population who would otherwise have to go to the emergency room, pay out of pocket, and if you've had to do that, it's hundreds of and sometimes thousands of dollars. So our school-based health center is a safety net for that. And so anytime a student who does not have insurance comes into our facilities, they are treated regardless of whether they have insurance or not. Any student who has insurance, the insurance is billed.
But if they have a deductible, you're not collecting it.
So that is up to
Okay.
the sponsoring organizations. That's not up to the Connecticut Association of School-Based Health Centers. The sponsoring organizations can, within legal limits, bill for the copay and deductible or choose not to.
Well, then I guess I can understand why they're closing, because what's your revenue source? you have to pay doctors and nurses and all the other stuff in that, but you don't have a revenue source if you're not collecting. So unless it's just Medicaid or what the insurance company may pay after deductible or co-insurance, this is, no offense, but this is a financial model doomed to fail unless you have 100% taxpayer supplement on top of whatever little you're getting through insurance.
Right. It's a challenge. It's a challenge that we've faced, since school-based health centers opened. The purpose was to work towards a sustainable model. And many of our school-based health centers have been successful in doing so. And that could be through foundation funding, through HRSA funding, and other sources. Lots of times their main site clinics are able to offset their deficits in their school-based health centers. And so that's been successful. The purpose of a school-based health center was to serve our neediest population. It wasn't to make money. And so that's why we come back to the legislature every year. And it's not from lack of effort from our sponsoring agencies to find those other sources. It is challenging because those funding sources have decreased significantly.
So Melanie, I'm gonna pause us there as I'm looking at our time, and would request if we can take this offline and continue to follow, if you can reach out to Representative Nuccio and follow up with this particular question. And we do have two other presenters, so I do see, Alice, your hand raised, but if you can enter it into the chat, I apologize. We do have other presenters, and so I want to pause us there, as we have the Bristol school system and the another school system that are prepared to present next. The next group is Erica Trini, Director of Climate, Culture and Engagement, Michael, Deputy Superintendent and the Superintendent of Bristol's Public Schools and Hamden Public Schools, Gary Hensmith. I think, Erica, are you starting the presentation first?
Sure, I'll start it. 1 second.
Good afternoon. Thank you all for the opportunity to present to legislatures and other stakeholders in the state. Erica Triani and I are facing hearing what's happening in the eastern part of the state is a little different than what we're facing. We have several very robust partnerships that we've been able to enhance through collaboration. Wheeler Clinic, SBHC, CHDI, CHC. We've been very fortunate with those collaborations and with that program development in order to provide services across the board for our students enrolled in pre-K through 12th grade. The slides that we're going to share with you, just quick indication, snapshot of who we are. Our overall enrollment is 8,250 students. We have about 22% of those students qualify for special education, which is higher than the state average, but not unlike other urbans similar to Bristol. Our multilingual learners, that number is increasing, currently at 561 students enrolled. Among our students attending private or public programs for special education related services, that's 178 students. And we have a continuum of programs in district that work with students in specialized programs, and that totals 240 student enrollment. For an indication of the acuity of services and another sort of snapshot moment, to date this school year, we've conducted 430 risk assessments. Those are risk assessments done by a certified or trained Bristol Public School professional. 40% of those approximately have resulted in outreach to 211. 93 of those resulted in calls to 911 for a transport via an ambulance. So that gives you an indication of some of the work that we're doing here in this area. we were asked by CHDI to identify, prioritize what are some things that you're grappling with and, issues that you face as a district. So we've identified 3 challenges, and I'll go through them briefly. Our first challenge is providing continuous supports and services across that pre-K through 12, grade band. And also very importantly is bridging students and families to those community-based providers. As a school district, there's a limit to what we can do within the course of the school day based on our staffing and our resources. So we find it's really critical for that next step to happen, which is the bridge to the community-based providers who do have the supports and services. So along with each challenge, we have a proposal for what might help resolve those issues. Standardization of database across districts and real-time funding solutions. We here in Bristol face a lot of transiency among our population, so that concept of portability would be really important so that we are able to access information in real time and able to make that connection with the student, family, and a provider. Looking at aftercare transition services that are sustainable and very importantly, skills-based. So we're looking to identify, what skills we need to introduce and how to support our students and families to become as independent as they possibly can be. And of course, with these requests or proposals would be the need for funding of the school-based health centers with those comprehensive services. So a family can, sort of one-stop shopping is what our families are seeking. And we have pockets of that existing in district. And where we do have that, it's highly utilized. And then recognizing that licensed and certified, specialized trained support staff are really critical to ensuring the quality of care, as well as the quality of the treatment plans and the programs, and the aftercare services that are needed. Policy implications, we're guessing. We don't know what we don't know, so we've been talking a little bit about what we may need from legislators, ways that they could help or others could help. Looking at clearinghouse approach by region, so who are the approved and vetted service providers, so that in a crisis. We do a good job of identifying who regionally we have, but again, looking at that transiency, it would be nice to be able to say, to a family who's maybe moving out of the region and help to have a seamless transition for them to that new district or that new location. Universal and accessible data collection for progress monitoring. I know there's likely going to be some HIPAA, FERPA implications here, but similar to what we do with our IEPs and the accessibility on CT SEDS on one platform, it would be, we would save a lot of time and create efficiencies if we could access that information quickly. That's, something that would be very helpful to us. And then pathways for districts to collaborate with local or regional officials to address what those long-term and sustainable funding solutions are. We've heard some of the problems that the SBHCs face. From our perspective, if we have it in our building, we don't want to be turning people away. The whole idea is around, immediate accessibility, and we would not want to be in a situation where we were turning a student or a family away, from those services that we've worked so hard to centralize. Challenge number 2 falls very broadly under funding, and from our perspective, funding of special education and related services. To fully fund those services beyond beyond what the excess cost formula, which is 4.5 times your per pupil expenditure. This would allow districts to bring a greater level of predictability to their budgets. And it would also, there's a couple other points that I'm going to make here that I think would assist in districts bringing a higher level of predictability to a system that is very expensive and costly is required. It's ethically and morally the right thing to do as well. But fully funding those excess costs to all districts would have a significant benefit to us. And then also looking at maybe creating a tiered system of, maximum daily rates based on what the student needs are. I know there's other states that do this. If we had a student who qualified for services as tier 2, and we knew what a daily rate was, that brings that predictability for budgeting and moving forward. We were told that, some districts aren't fully expending the funds, the federal or state grant funds. And, if you give us money, we're going to find a way to spend it. So, looking at establishing either a reserve fund or some other type of program which districts could have access to. So if there were money set aside that people are leaving on the table that a district could appropriately utilize, it would be nice to be able to do so. A system that addresses the variability of enrollment after we adopt our budget. We just adopted our budget here in Bristol. Local funding is going to be $130 million. And I do know that our numbers are going to change pretty dramatically among our high needs population. So, what is that system? It may be going back to the first bullet, which is fully funding excess cost, but anything that could be done to increase the predictability and supported districts around, these volatile budget variables would be helpful. And then Medicaid reimbursement for approved services. Many districts, in order for that to be viable, have to contract with a third-party vendor. The dashboard, the unreliability of the platform, these become obstacles to districts being able to fully realize the Medicaid reimbursement. So if there's a manner in which that could be addressed, I often am hearing from my clinicians and others that they're spending, on the weekend, they log in and the system is slow, or the system crashes and information is lost. So anything that could be done to create a more reliable system there, I think would improve our ability to seek those that federal dollar and that federal reimbursement. So implications from our perspective is having guidance on a tiered tuition fee structure that the APSETs, the approved private special education programs, know ahead of time. That would be helpful. Guidance and advocacy on accelerated Medicaid application and reimbursement, and then conversely providing funding to administer that Medicaid process. As I identified, the dashboard and filing is sometimes an obstacle to us to fully realize. So that would be helpful. Lastly, challenge number 3, addressing roadblocks that schools and families experience around services. So proposal would be to empower credentialed school personnel to request transport of children in crisis to resources that can address those complex needs. When we call 911 and when we activate 911, there are protocols around going to the nearest hospital, their nearest facility. Based on our experience, there are some resources that are prepared to work with a kindergartner or a first grader. There are other resources that are prepared to work with an adolescent. They're all within the region and having some ability to make that request or at least influence that outcome, because ultimately that's going to get the supports and services to that family quicker. That would be helpful. We know from our friends at DCF and JJC that they have spots allotted or set aside in ICAPs, in that we would really like to have maybe spots distinguished or set aside, such as ICAPs or MST, where we could accelerate or work through a waiting list. Or if there's open spaces, why are we not providing that resource to a needy student or family? And then those aftercare transitions after the crisis or hospitalization. I'm thinking old systems of care and those models where we really created seamless transitions and follow up in ways that were helpful and supportive to our families. Implications for here would be addressing those regional disparities of resources that we heard about, from other representatives today, and ensuring all emergency departments have emergency psychiatric supports for children on their respective staff. So when the student arrives, or the child arrives, we're not awaiting, the arrival of that resource. And we have run into that regionally, and that may speak to some workforce development or other things that need to happen statewide. So I've been talking fast. I know we're running out of time, but I wanted to make sure we covered the material. Eric and I will put our emails in the chat. So if you need to reach out for further clarification, we're happy to do that.
Thank you. And Superintendent Highsmith?
Good afternoon. Somebody could project the presentation, I'd appreciate it. So I will stick to the rule of the 5 Bs, which is be brief, brother, be brief. So I'm gonna stick to that rule and we're gonna keep it moving. If you have questions for me, you can feel free to either, if there's time, to ask them now or ask me in the future. So we can go to the next slide. So you're taking a look at our student enrollment. We've got about 5,500 students, not counting outplaced students. 21% qualifying for special ed, and 481 multilingual learners. We had a significant increase from last year to this year in multilingual learners as well. And it's one of our biggest challenges, in addition, obviously, to special education. We have a really robust in-district special education programming from pre-K all the way through transition programming for students up to age 22. Next slide, please. So one of the challenges for us is to continue to provide a robust system of mental health supports at all grade levels. I'm very fortunate in our district. We have a robust system of mental health supports for students. Last year, we had 1 school-based health clinic at our 8 elementary schools. We now are up to 4 this year. I'm very happy about that. We also have a robust program with Clifford Beers, providing support, comprehensive embedded mental health support for us at our middle school and our high school. And this is the 2nd year for that program. And our provider for the school-based health clinics are Cornell Scott Hill Health Center. And they've been absolutely phenomenal. And even we also have Cornell Scott at our high school, providing school-based mental health supports and behavioral health supports. We're actually expanding that program at our high school this year. So a few of the things to take note of here: we do need technical support provided to school districts in terms of grant writing. I'm not expecting that the State Department of Education or the legislature is going to be able to provide the money that we need. And some of us don't have grant writers in our district. So it'd be very helpful if we could have some support with that. Where there isn't sufficient community-based mental health supports, we do need money to make sure we have those school-based health centers that provide those supports for us. Provide an embedded whole family trauma-informed integrated model of care. That's what we have. We're fortunate to have that model at both the middle school and the high school, as well as the 4 elementary schools, 4 of the 8 elementary schools in our district. So, because if we're not providing supports and making that a whole family model, the chances of our students being successful in isolation of their families getting support lowers significantly. We use a lot of assessment data to determine how we approach what we do with our kids, and we need increased clinical and care coordination activities at our schools. So care coordination involves people dedicated to working with families in their homes if necessary, making sure that we meet their basic needs. If they need help with rent, if they need help with groceries, if they need help accessing sort of community supports, the people at Clifford Bears, our care coordinators, work with them in that regard. And one of the great things about Clifford Bears and our relationship with Clifford Bears, and there are many great things, is that this is a program that goes beyond the school day and beyond the school year. So it doesn't just end in the summer, because students' mental health challenges don't end in the summer. So they actually engage students in the summer as well. You can go to the next slide. So the policy implications for that is that we have to fully fund, I believe, a department or a bureau that's solely dedicated to working with schools to enhance school-based mental health supports. I think what happens is those responsibilities are found in several different departments at the SDE, and the SDE has been great in being responsive to schools, but we need a department or a bureau that focuses solely on those mental health supports and mental health needs for schools. And there has to be some communication between policymakers and the SDE and community-based mental health providers that's ongoing. And so that it's not just around the time that you're in session or when we're having these committee meetings. It has to be an ongoing process so that those making decisions have all the information up to that moment. That would be helpful. And emphasize care coordination so that the entire family is included. Next slide. So challenge number 2 is enhancing the role of parents and caretakers in the mental health of students. So we emphasize care coordination because we understand that if we don't work with the entire family, the odds of us being successful with a student lower. So we want to make sure we increase the sense of self-efficacy on the part of adult family members, because once they leave us, they spend a great deal of their time with us. But in the summer, they're not. After school, in many cases, more than like an hour and a half after school, they aren't. On the weekends, they aren't. So adult family members for students who have some mental health challenges, who need supports, have to be able to also provide supports while they're not in school. We need collaboration between direct caregivers and treatment professionals. A lot of times there's a gulf there that really is nobody's fault, but sometimes there's a connective tissue that certainly doesn't exist. We have to emphasize that and find a way to decrease internalized blame on the part of adult caregivers, because in schools, as people who work in schools will tell you, parents and adult caretakers do internalize blame when their kids are not successful. They think it's because their parenting is ineffective, as opposed to looking at a much larger sense, getting a much larger sense of all the environmental factors that impact that. The next slide. So the policy implications for that challenge is to provide funding for enhanced collaboration between community-based providers and school system personnel, streamline and intersex eligibility for services with other processes. A lot of times these things are disconnected from one another. And I think we can say with great confidence that if there's an issue of poverty, there's likely to be an issue of mental health challenges for those students for any number of reasons. So if we know that, let's not act like we don't, but let's make sure that we streamline all those processes that'll be supportive for families. The SDE and other appropriate state level agencies provide direct family access to available resources so that we know that we don't just have a local array of supports that families could access, but there might be larger and even more effective supports at the state level for families. Next slide, please. The third challenge is resources for schools for continuing care and support of students who suffered serious mental health challenges. Those of us in schools will tell you this. One of the greatest challenges that we're facing, and I believe it's true for many schools, is that there are students in grades K through 2 who are so extremely dysregulated that it's hard to even teach those students, and it's hard to maintain control of a classroom, and it's hard to provide an education for them, especially because they don't have the skill set to self-regulate because they're so young developmentally. They don't have the skill set to self-regulate. So we're asking our teachers to do things that they're not trained to do, to deal with situations they're not trained to deal with. And we're asking school social workers even to deal with situations many of them may not be trained to deal with. So if we don't have another level of support for those schools, we're going to witness a cycle where these students are really never going to get the mental health supports that they need. They're going to get older. Their issues are going to get more systemic and more deeply embedded. And in 4 or 5 years from now, we'll be looking at a system of schools that is having significant difficulty in dealing with those students. It might be hard for people who don't work in schools to believe that students in kindergarten, first and second grade are as dysregulated in some cases as they are. But we can all tell you instances where that is. So it's a significant challenge for us. And a lot of times schools don't have the technical supports and other supports. You'll find staff members spending all day chasing after students who are in kindergarten or first grade who just don't have the wherewithal to sit and process. But remember, these are students that 4 years ago were 1 or 2 years old in the midst of a pandemic, where that pandemic not only negatively impacted their ability to socialize, but actually removed their ability to socialize. People had to stay away from each other instead of being with each other. And when you impact a young child's development that way, there are consequences for that. And the schools are the ones primarily seeing the consequences of that happening. And everybody's doing the very best they can, but this is something we never saw before and something we may not be prepared to deal with on our own. Next slide, please. So the policy implications for that third challenge is to provide ongoing resources for students who are scheduled to return to school after receiving treatment for serious mental health issues. Everybody's overwhelmed. The entire system is overwhelmed. And school systems are becoming the one social institution that's being asked to do more and more and more, but being given less. You heard my colleague talk about the funding in his district. We're $3.1 million short of what we asked for from our local legislators. And so we're dealing right now with a situation where I've got to find a way to get that $3.1 million down, because we can't have a deficit. So while we're being asked to do more, and especially in terms of students' mental health, we're actually getting in the aggregate less than we were before. Providing ongoing technical and other supports for elementary age students and the staff whose students display significant levels of dysregulation. And there has to be some sort of interim school setting when a student leaves a place where they're getting intensive supports. If they leave a place where they're getting intensive supports and come directly to schools, we still don't have the resources, I don't believe, fully to address and provide supports for them. So that's pretty much it in a nutshell. I try to keep it as brief as possible, and I'll stop here and see if anybody has any questions.
Thank you. Thank you so much to the school representation from Bristol and Hamden for that presentation. Any questions from the membership? Okay, thank you. I will give the floor to our tri-chairs so that they can do a legislative update.
I don't believe we drew straws on who was going to go first. So happy to defer or take the charge, whichever you prefer.
I think given the time and wanting to be sure we delve into things, why don't we have Claudia lead us off with some of the financial piece, and then we go from there with my recommendation.
And if I could just, I know that Alice, you had a question or you wanted to share some information previously, and we had said we would leave questions for the presenters until the end of the presentations. Should we just give a couple of minutes to that first, Erica, so that people can share that information or ask questions, and then we can go into Claudia leading us off.
Yeah, Alice, do you?
Yeah, thank you so much. I really only wanted to sort of talk about the funding, and I know that for next year, next session, I think we're going to continue conversation on school services. So I'd be happy to work with the team on sort of pulling out a little bit more information. Representative Nuncio, I wrote you an email saying I'd be happy to chat with you, on the side if you want to do have some conversation, and certainly Senator Austin. But I think that there are some really there's some opportunities that Connecticut might be able to link into that have been across the states. So and the reality is all of us who are providing school-based services, in particular who are not FQHCs, are significantly losing money every contract we have with the school-based services. And that's just the reality of the work right now across the board. So I'm saying everyone. I don't know if everyone is. I have a lot of my colleagues on the, if they're not, would you reach out to me and show me how you are not? But it is very, very difficult to use a fee-for-service model in a school. So anyway, that's just my thought.
And Alice, I think what you just reminded me is, and an update is that one of the work groups that we're going to activate later this summer is the school-based behavioral health work group. And so I do know that the chairs will be engaged, and we have some candidates who submitted their resume to be considered as co-chairs for that work group. And the tri-chairs will be engaged in the next few weeks in interviews and then appointing chairs for that particular work group. So this actually comes in good timing, as we can, as information that was presented today can be very useful in the development of a work plan for that work group, as well as compared to the legislation that passed that was charging this committee to initiate that work group. So we will be in touch, Alice. Thank you. Anybody else before we switch it over to the chairs or to Claudia? Yes, Christine.
And I know Claudia is ready to give that legislative update, and I'm happy to my colleagues for all of the work that was done. Just a comment, first of all, I would like to thank specifically Superintendent Highsmith for one of your last bullets about the internalized blame on the part of parents. And I know children's behavioral health is in the context of families as well as schools, and appreciate you recognizing that piece in the role of adult mental health and parental mental health as we try and help our students. But I guess the one piece in terms of the social determinants of health in the earlier conversations related to our providers' reasons for leaving the field, which was money. I also think about our ability to pay for housing as providers, and that we can't address all the issues, but I can't help but think about that as something that, even if it's not something we directly take on in our working groups, that we look at in terms of being allies with others who are addressing that issue, because it has a tremendous impact on people's ability to afford to live.
Thank you. Sherry?
Yeah, I just wanted to share, one, I want to thank everybody. I think the presentations were wonderful and strong. Kids in Crisis has been really fortunate to have robust relationships with school districts throughout Southwestern Connecticut for probably close to 25, 30 years, in which we provide a full-time clinician in the school all school day, all school year, and then after hours have our 24-hour services back it up and through the summer. And it's funded in a variety of different ways. And yes, I agree with Alice. I mean, it's underfunded. We are fortunate to find amazing clinicians that are really very focused on the work. They're in Boys and Girls Clubs. We just started our first elementary school program this year and have received funding to pilot it elsewhere as well. So I'd love to share that data. And we are having a summit this summer. We have an annual summit. It will be July 22nd. We do it when school administrators are more available. And this year's summit is focused on funding and sustainability.
Would you mind sending that information over to us, and then we can share? Is it okay to share out some of that information?
Absolutely.
Okay. Thank you so much.
Absolutely.
Thank you.
I'll make sure to, I'll send this save the date to you.
Okay.
But we've got great data from 30 plus years, and each program is funded a little bit differently than the next. So it's interesting. Some are private, some are town funded, some are Board of Ed's funded, some are school specific funded.
Okay, perfect. Thank you so much. All right, any other questions before we give the floor to Claudia? I don't see any. Claudia, you have the floor.
All right, thank you, Erica, and I'll try to be brief so we have a few minutes for questions as well. And I think Senator Mar will also add one of the big achievements that she championed through the Kids Committee. But taking a step back, I want to first commend and reflect on the success of TCB just as an entity. I think the fact that we're having conversations and seeing providers and understanding the gaps that exist in our system all at the same time and processing that information throughout session has made for a very productive session. I know I relied heavily on a lot of the members of the TCB for informal conversations and feedback in the halls of the legislature and throughout the budget negotiation process. So I appreciate that. And I think it's a testament to what we've stitched together here as a TCB legacy. So in terms of policy, first, I will reflect on some of the presentations today. We've heard over the past few years with COVID that workforce issues, workforce shortages, in particular in the healthcare space and clinical settings, has been a pain point and one of the barriers to both access to care and a pain point in terms of private providers being able to afford and sustain their services. So very pleased that this year there was significant effort to look at ways we can deploy interstate licensure compacts and promote the use of telehealth. So 3 bills in particular, one from Representative McCarthy-Vahey, champion in public health, about expanding the telehealth requirements and ensuring that those out-of-state providers that provide behavioral health services could continue to do so without having to go through all the hoops and registration process on the front end. It sort of has an expedited process for initiating and continuing their services with the requirement that they subsequently figure out the licensure through DPH, which will be very important for our behavioral health providers. Secondly, again, coming out of the Public Health Committee is the Social Work Compact. We hadn't anticipated that so many states would be interested in joining that right off the bat, but I'm very pleased to see that not only has Connecticut led in being one of the initial states to adopt that compact, but several others have as well. So it may be possible for that compact to go into operation in a year or two. So the Social Work Compact, again, very similar to the Nurse Compact, which is the third of the bills that address some of the workforce issues, would allow for reciprocity and shared practice across states for those that are members of the compact. So the Nurse Compact being the third, it was a governor-led initiative. It allows Connecticut to join in jurisdiction with 41 other states or jurisdictions, allowing nurse practitioners to be able to practice across state lines, do telehealth practice. Also very important from a nurse education standpoint. So we've heard from communities, including some of our academic institutions, that say this is an opportunity to expand capacity for adjunct professorships and preceptor clinical placement opportunities pre-licensure. So very important to see those portability and licensure investments made through the policy side. On the resources and budget side, certainly been a banner year, despite the fact that we did not open up the budget or make significant changes to the budget. The stabilization package that was passed by the legislature includes very significant investments in mental health, children's behavioral health in particular. So one, the FY25 budget will have $7 million set aside state share. That's matched by federal resources. So you're looking at least $14 million annually of Medicaid rate increases that will be directed to children's behavioral health. This will include everything from intensive home-based services like ICAPS to also some of the other supports that happen in outpatient settings, also clinical providers, psychiatrists, social workers, sociologists, social workers, all those can be eligible for potential rate increases. And the rate increases will be informed by the actual evidence from the Medicaid rate study that DSS has undertaken with an outside consultant firm. So it'll be evidence-based. It'll look at how we match up in each of those codes to our benchmark states, our peer states, as well as if there's a Medicare component, we'll also look for a comparison to the Medicare rate system. So that will be an investment that happens there. Secondly, urgent crisis centers have been one of the new suite of services that this committee has long championed, and happy to see those stand up in the first wave of ARPA funding. There's an additional $7 million in the next fiscal year that's been allocated through ARPA. There is a question about, is this one-time funding and how does that work? I will say that it's one-time resources, but it can be staged over a couple years. So the obligation, either by way of a grant or contract through DCF, needs to happen by the end of this year, but the monies can be expended all the way up through the end of 2026. So we ought to be thinking about these ARPA dollars. Yes, they're one-time resources, but they can be multi-year investments and really help us going into the next biennium as well. So important for shoring up our urgent crisis centers moving forward. Additionally, with urgent crisis is that DSS has formally established the codes that are necessary and reflective of the billing and the services that are provided at UCCs, so that if a Medicaid client comes into the UCCs, they can now bill Medicaid and be able to claim reimbursement. Those are interim rates set based on cost and analysis that DSS has done. And we also know that since those now are embedded in our Medicaid system, if we have any decision to expand or stand up additional UCCs, those UCCs will also benefit from those new Medicaid rate codes that they can bill to for their Medicaid patients. Finally, in terms of resource investments, there's $10 million set aside in DCF for children's behavioral health, mental health. We see this as being an important force for helping to strengthen and stabilize the system. There's a very short period of time to be able to obligate these resources. So it's not going to be an opportunity for creating brand new service types or initiating new services. It very much is going to look at what's worked, what do we need to shore up and strengthen, and what are the plugs in the Medicaid rates. So if there's Medicaid rates that are not extending to certain parts of the continuum, how do we use that flexible funding through DCF to wrap around and strengthen the full continuum of children's behavioral health care? I think that as we look to finalize the investment approach for that 10 million, we ought to be thinking about potential opportunities like the UCCs, where we can initiate using ARPA dollars, but eventually they can roll into a Medicaid system or a commercial payment system so that the sustainability is built in the out years. I'll pause there and see if I think maybe we want to finish all three. I know Senator Marr has at least a couple pieces, or at least one she wants to talk about, and then we can maybe take a few questions.
That sounds like a great plan. Thank you, Claudio, because I know that the theme that came across from every presentation, whether it was school-based healthcares or the school systems, both Bristol and Hamden, and also CHDI, was the fact that we need more money. Everyone needs more money, both for reimbursement, for services, for paying of staff, and also bringing more staff into the field. So I appreciate you giving us an overview from the financial standpoint. And I also want to thank the school systems for not only putting forth what the issues are, but also putting out what the policy implications were for those problems. So thank you both very much on that. And I wanted to reach back to, I know Melanie had to get off, Melanie Wild Lane had to get off, but I actually heard something that I haven't heard before, and I wanted to just make a point of it, which was that COVID showed us the impact and the need for mental health services and broke us wide open. And I would posit that that actually existed at some level before COVID, but now we are fully aware of it. So we are still in the process of coming to grips with that. How do we provide the services? How do we both show the need and create the systems, which is part of what TCB is doing. But I, for one, as someone who was a clinical therapist years ago, really appreciate the change in the way that we are looking at mental health and the way we are looking at the need for awareness of mental health for children. So I just wanted to make that point. It's a reframing that I haven't heard before, and it actually made me smile and write it down. So that being said, we do know that there are a lot of needs. One of the things that we did in the Children's Committee this year it passed through both parts of the legislature and actually is going to go into law, is putting together a working group to develop a behavioral health intake form for children. How that is going to look, what the components of are going to be, where it's going to live is all what's going to be developed within the working group with a report back to the legislature. But this was something that parents who started as early as 3 years old with their children, bringing them to different providers and never having the information for that particular provider in a consistent way because every provider asked for something different. We are going to bring together a working group to develop this behavioral health intake form for children. Now, whether or not it goes because of HIPAA, because of privacy, whether or not it actually lives on a website and in the cloud, or whether it is just a form that parents can download, fill out, and bring with them everywhere, those are all questions that are going to come up and be discussed, and recommendations will be made. But I was very pleased to be able to do this. And for the most part, I'd say there seems to be relatively universal approval of this idea. The second thing we are going to be doing a working group, well, there's two more things. One, we talk about children's mental health, and we talk about the hate speech that's happening in our schools and across our state and across our country. And there's a significant impact on children for that. So this particular bill was to look at what is the impact on children, but not so much. I mean, are we going to find something new about what the impact is on children? No, but it gives us a jumping off point to have a conversation and do a review across the state of what are the programs that are working, what are the bright spots, what can we bring back to the legislature to look at as a program. The third thing is grief. We know that children have part of mental health is dealing with issues around grief. And we know that there has been much change and much grief that children have had, and it does affect them. It affects families, it affects communities. And a lot of this came out of COVID. This was a bill that we were bringing through children's. It did not end up going through children's because it went into education, but they are doing work around this as to what the programs are that can be offered to children around grief and processing the grief and counseling across the state. So those are three things that I think are really great. I also wanted to reference the silos. Several people mentioned silos and the way that we are working in silos. And I just want you all to know that I am tremendously committed, as I know my co-chairs are, to breaking down those silos that we have. And as someone who was an executive director for 20 years and was used to raising money and getting things done, being in the legislature is very different. It is far more incremental. It is far slower. And just know that there are times when I look at this and go, what are we actually doing? The crisis is now. We need to get this going. We need to make a difference. And then I talk with Representative Exum, who goes, oh my gosh, we've come so far, because she knows the way the legislature works, and I'm still a newbie. So just know that we are still all committed to not just learning from each other, but also actually accomplishing. And we really appreciate, I know I say this every time, but I really appreciate you being here. And the expectation is, just to reiterate, we were talking about this in a meeting this week, we are putting together a strategic plan in the fall with recommendations for next year's legislature. So I wanted to close my comments on that point. And I'm sorry, Tammy, I only left you with 4 minutes. I apologize.
Oh, and that's absolutely perfect. Thank you so much. And as you say that, I'd just like to piggyback on what you're saying, because we hear the need, and hearing the school piece of it reminds us that the issues we have at home are connected to the issues we have at school. It's the same children who are showing up in all these different environments, and the needs are there. And it does move very slowly. But when I look at where we were during COVID and coming out with this legislation, and now really trying to minimize silos, bringing all of us together, people who've cared and worked on this for such a long time, people who've been here a shorter amount of time, but really dedicated to this work. And even having our urgent crisis centers open, I mean, that really is, I think the biggest area there, as we've discussed, is really having people understand that this is a resource, understanding that so that parents will utilize those centers rather than thinking the emergency department is the only place to take our kids. So that's one area that we can be proud of, but we need to do a lot more work around. And then I was listening to the earlier presentation, Dr. Bracy, when she mentioned how the peer-to-peer work amongst students in the schools, which again came from that legislation, that is something that they are now starting to do. It is slow. It's frustrating to hear that funding that's allocated 2 years ago, they're just getting online now. Well, we know the urgency of this was immediate and is immediate, but given the way the system works and how you're talking, Senator Mara, about being accustomed to getting it moving quickly, there is progress, but there is a whole lot more to do. And I am so encouraged by this committee with what we will be able to continue to tackle together, recognizing that we're dealing with a lot of need for so many reasons. The COVID piece, as our Hampton superintendent referenced, the kids are coming in looking very differently. When you miss some of those developmental milestones, you miss them. So how do we work on that and prepare for that moving forward? So I think we were given the complexity of the short cycle and having to do more of a stabilization plan. I still feel that we have gotten some funding that is really important, that will allow us to move forward in this way. And we can always look for ways to continue to tweak and move forward. I do want to leave time for Erica because we have a big day coming up. And legislatively, I think all the highlights have been given by my co-chairs. But Erica, I'd like to turn over to you so you can get us ready for our next event. It's wonderful to see you all. Thank you so much.
Thank you, everybody, and thank you again to the chairs and to all the presenters for spending the time today. Again, just a reminder, Monday is our TCB Strategic Planning Day, Phase 1, and this will be a multiple series phase. Our goal is on that day to brainstorm away on specific areas. We've done several months of level setting, so we will have quite a bit of content for you that has been refined in the sense of narrowed down so that they can be used throughout the day. We will be breaking up into groups to engage in identifying specific goals, and as I mentioned earlier, strategies to achieving those goals. And our plan is that after that June 3rd, after Monday, a lot of the content that we obtain from that day will then be processed throughout the work groups, and then it'll be a back and forth between work groups and up to the TCB committee here, where we'll keep you informed and obtain your feedback month after month after month, so that we have a robust and comprehensive strategic plan for you all to approve at the end of November, early part of December. As Senator Marr identified earlier too, it is our intent to have some legislative recommendations for this committee to review. And it may be that there are sort of the short-term bucket list and then the long-term bucket list. But that report with recommendations will also be coming to you at the end of November, beginning of December. We have several partners who are providing support in that, and that is UConn Innovative Services, as well as Dr. Whitson, who is on this call right now from faculty at University of New Haven, who are helping us in doing two things, multiple things actually, not just two things, but looking at landscape of services, as well as data infrastructure, as well as just overall governance of children's behavioral health. So quite a bit of information that will be and work that will be taking place in the next few months. Again, Monday, very critical. Join us at 8:30, check in, programming starts at 9. And we will have plenty of coffee for you. All right. And lastly, because we have you engaged for a full day on Monday, there will not be a June TCB meeting. The next time we will meet will be in July. But Monday you will be engaged in a full day, so that's equivalent to 2 full meetings.
And
Senator?
if I might just also add, we will not have a meeting in August.
Correct.
So we hope that you'll be here in July as well as June so that we can then take our break.
Yeah, correct. Work groups will be working, but the membership will now, because we'll take advantage of that month in August to really dive deep into some of the healthy debate and data review. So with that being said, that is it. I will see many of you on Monday, June 3rd.